I'm Rebecca Nielsen. It's so nice to see you. Thanks so much for coming. I'm just going to jump right in and introduce the opening keynote, which is going to be a panel discussion. We'll have some time at the end for questions, so be thinking as you hear the panel discuss some topics and be ready to share your questions with the group. So the panel will consist of RyLee Curtis, Community Engagement Director, University of Utah Health, and board member of the One Utah Health Collaborative, Jennifer Strohecker, Medicaid Director, Utah Department of Health and Human Services, and Jaime Wissler, Executive Director, One Utah Health Collaborative. I'll invite the panelists to come forward. And we're going to kick off with Jaime giving us One Utah Health Collaborative 101. What is the collaborative? How does it function? What are its objectives? And then we'll transition to a less formal panel discussion, and then we'll save some time for questions at the end. Jaime, welcome.
Thank you, Rebecca. I'm Jaime Wissler, and good morning, by the way. I'm the Executive Director of the One Utah Health Collaborative, and I'm honored and humbled to be here today. It's so great to be here at the Salt Palace Convention Center. As a lifelong Utahn, I stood here as a 15-year-old for my first ever rock concert, AC/DC's Blow Up Your Video Tour. It was awesome. And as I stand here as a 50-year-old, I'm equally excited today. Okay, maybe not as excited as I was watching Angus Young come out of this smoking missile, guitar in hand, right? Just rocking it, but great memory and fun to be here today. We'd like to thank the State of Reform for featuring the collaborative in this opening keynote. We're not shy about taking this slot because the collaborative is something that everyone in this room can participate in, and I hope that you will. The purpose of my remarks is to orient you to the reason of how the collaborative was formed. And let's see, I am the worst with technology, but look at that. So our end result is our vision, that Utah will lead the nation in affordable health care that improves the quality of life for all Utahns. Before we talk about our approach, we need to be clear on the why. Often we hear of national challenges with healthcare and its impact on cost, quality, and equity. But this hits home in Utah. We have a self-perception, maybe even a misconception, that Utah is a healthy and affordable state, but the data says otherwise and is reportedly skewed by the fact that we are such a young state. So we must address this issue. And the increase in healthcare costs, we know, affects everyone. For individuals and families, increased costs are eating into household budgets, reducing take-home pay, and making some choose between going to the doctor and putting food on the table. For employers, and especially small employers, they're burdened by healthcare costs, making it harder to stay competitive. Every additional state tax dollar that's spent on healthcare is $1 less spent on education, infrastructure, social programs, or lower taxes. At the same time, we are not getting better outcomes, and they are unequal. Give me one moment with my notes here, please. So before I speak to our unique approach in addressing the problem, I want to emphasize the reason for the structure and the time horizon. So the One Utah Health Collaborative is an independent, nonprofit organization, a 501c3. It's community owned. We're both public and privately funded. It's also community governed. Its priorities and activities will primarily be dictated by community consensus. This community consensus allows for collective buy-in and collective impact. The lifespan of the collaborative is also unique. Dramatic improvements in healthcare cannot happen in an election cycle, and Governor Cox recognized this. So while the funding in the foundation of the collaborative was supported by Governor Cox, it's designed to far outlast his tenure. This is a 15-year initiative with no abrupt changes, and it gives us a runway to build into this system without having to uproot overnight. We focus on problems and solving problems through collaboration and innovation, not through regulation, not through mandate. Our ultimate goal is to ensure that Utahns have access to high quality, affordable care regardless of income, race, ethnicity, gender, and geography. This is reflected in our 3 target goals of affordability, equity, and outcomes. These solutions focus on both health and healthcare. That's why we are the One Utah Health Collaborative. To achieve these goals, the collaborative has 3 primary functions, and it looks like we're maybe already there. 3 primary functions of commit to action, align the community, and accelerate innovation. So key players in the healthcare community have signed our pledge, agreeing to support 3 goals of accountability, equity, and outcomes, and assume ownership of the problem. Several have taken it a step further, embraced the challenge, and pledged community-specific goals to advance the collaborative's vision. In fact, RyLee through UHealth has done this, and Jen Strohecker with Medicaid has also done this. We probably have, I suspect, 15, maybe 20 of these in place. So that is a great example of taking it a step further beyond our basic pledge. We act as steward of the pledge to promote accountability for stakeholders, continued collaboration, transparency, and progress. We are responsible for measuring success of community action and ensuring that we do not become stagnant. I want to emphasize, we do not police these efforts. I spent 25 years in federal law enforcement. I'm done with that. We are not policing these efforts. It would not be effective here. So over 50 executives have signed this pledge, and I would encourage you to do the same. And you'll see our website and the way to go in and do that when we wrap up today. But those that sign the pledge include our largest insurers, our largest payer groups, and other organizations that are committed to this vision of being part of the solution. Second, we align the community. This function is serving as conveners. We have the unique opportunity in Utah to align our healthcare community. Stakeholders have an opportunity to put the common good ahead of business advantages and commit to reform in a community-centric way. We will facilitate reaching consensus on specific goals and will help align the community on how to navigate transformation together. Our most recent example of aligning the community is our digital health pilot, where we are addressing data interoperability. We convened our community board on April 10th and formed our digital health working group to begin work on this unique pilot. Key players came to the table and committed to collaboration. For me, the most exhilarating part of this new position has been watching the evolution of our third and final role, which is to accelerate innovation. This is the overarching principle and the key to our success. We know that Utah is one of the most innovative places for healthcare, where we prioritize innovation over regulation. We address challenges that come with innovation: lack of awareness, lack of partners and siloed efforts, lack of reliable data to demonstrate value, and lack of funding. Our four main approaches to addressing barriers and accelerating innovation include promote. We highlight existing new innovations and increase awareness. Connect. We connect innovation leaders with our key stakeholders and our community board members. Assist. We help measure and analyze the effectiveness of an innovation, and we attempt to scale it. Fund. We financially commit to advancing the innovation. We started the process of forming an innovation advisory committee, which will provide guidance to the collaborative on how best to support innovation and assess new innovations that are coming in. Multiple projects and innovators have already approached us, and we're in the process of assessing how best we can help. This is a focus area, and we're excited for the evolution in healthcare that will come out of innovation. I'm going to take a little more time, if that's okay, and I think Jen and RyLee are okay with that. I want to, let's see if I can go back. Glad I grabbed the one that has the back button. Okay. I want to issue a call to action, and we can talk more about this as we wrap up, but we want you to become a collaborator. Although we're new with plenty of challenges to overcome, we're thrilled to see genuine engagement from our healthcare community leaders and our progress to date. The collaborative's consensus-based approach to achieving system-wide change in healthcare, we believe, is revolutionary, and we're excited to see positive outcomes. It will take all of us to achieve this mission, and we want any and all Utahns who are passionate about health equity and affordability to be involved. So if you want to be a fellow collaborator and commit to improving our healthcare system, please reach out to us. And I've already talked about how awful my vision is, so I'm going to come and look at the monitor here. You can join our team. We have a digital health working group. Many of you, if you receive our newsletter, received information on this. There's an application process. There were follow-up emails that were sent. If you didn't receive something, go to our website and take a look, or reach out to me. So our Innovation Advisory Committee, Digital Health Working Group, same thing. You're welcome to approach us, and we can see if you can help out in that effort. We also happen to have, here's my plug right here, we have a job announcement open right now for a director of communications and marketing. If you're interested in that, again, access our website. It'll take you where you need to go. Innovate with us. That means you can connect us to existing innovation, right? Because that's what we do. The collaborative does not create the innovation, right? We are the steward of this effort, right? We try to promote and scale. And so approach us with that. If you have submissions, make a submission. Sign our pledge. Come in, take a look, see what you think, sign our pledge. Be a part of the solution. Take it a step further, like Jen and RyLee, do an organization-specific pledge. And finally, connect. Reach out to us on LinkedIn. We will be developing more social media platforms, but take a look and connect with us. So again, I'm grateful that I could give this intro. Special thanks to Rebecca, RyLee, and Jen for allowing us to do this and kind of kick off this panel. Thank you.
Jaime, thanks so much. Let's go ahead and jump in. And at the signing event for the One Utah Health Collaborative, Governor Cox made this statement: addressing the cost of healthcare has become an economic imperative. And I think most of us would agree with that. Jaime, you mentioned affordability several times as a central tenet of the collaborative. Could we unpack that a little bit? What's the vision for the collaborative to address affordability?
Yeah, so we do not believe, no one effort is going to make a day, right? There's too many siloed efforts out there right now. Affordability, I think you need to look at outcomes and you need to look at cost. And we do that through the lens of equity, all right? So if we're looking at this, we envision not just hundreds, potentially thousands of incremental changes in the community. And again, we're looking at the state of Utah. That doesn't mean that we don't look at innovation outside the state and apply it to our community, to our residents. But this effort will take hundreds, if not thousands, of incremental changes. We also know that this isn't designed to happen overnight, and that's the beauty of the collaborative. Many of these efforts have come and gone, and we are unique in so much as we have this 15-year runway. And as I sit here, I'll say, I'm new to the industry. I have 7 months. The learning curve has been steep. It's been fun to see. Again, I came from federal law enforcement. But I can see already that this absolutely needs to be a community effort, and that's why we collaborate, and that's what got me excited about coming on board. So that's how we see cost, and I think we'll get later to metrics and growth targets and ideas we have about how also to tackle that.
Jen, anything you'd add about kind of the nuts and bolts of tackling affordability?
Yeah, absolutely. So one of the key features to affordability is really rooted in the patient experience and the patient outcome. And we believe that addressing the cost of healthcare can be best achieved when all Utahns are able to experience timely access to care and receive the healthcare that really will help them achieve their ultimate health outcomes. This means continuum of care as well, so from infancy to adulthood, that individuals across our state have access to these services that meet their unique needs. We believe that it is very possible through the efforts of the Health Collaborative to achieve these goals, to take down the silos that exist in the patient journey today, where the gaps in care occur, where the barriers that interfere with health outcomes interfere with individuals achieving these goals. We believe this is possible through partnership, through collaboration, and by really engaging in patient-centered outcomes as a critical piece of this journey. When we're focused on outcomes, we know that there's health achieved, and also that makes healthcare more affordable. So using data and bringing that patient voice into the work is another piece of affordability that I think is critical in the Health Collaborative work.
Yeah, and is that on? Okay, so I think as an institution that has, sorry, I feel like that's not me. As an institution that has submitted proposals to the One Utah Health Collaborative, I'll just speak from that perspective. And we really see that the One Utah Health Collaborative can support ideas that have proven cost reductions and have sustainable financial models. And oftentimes these programs are unable to scale due to financial or policy barriers. And we see the One Utah Health Collaborative being able to help be stewards of those innovations and find solutions to be able to scale up these programs. So University of Utah Health has submitted three proposals, and all of them have shown to have better health outcomes and to lower costs for patients, but could benefit from partnering with the collaborative. So just briefly, we have the intensive outpatient clinic, which is an interdisciplinary team, which services mental health, social determinants of health, and medical needs of a very complex and high needs group. And we've been able to reduce the cost to both the patients, the insurer, and the healthcare system through that program. We have the Huntsman at Home partnership that we've submitted as an innovation, which is in partnership with Community Nursing Services, which brings hospital at home services to people throughout Salt Lake, Carbon, Emory, and Grand counties. And then lastly, we have the HMHI home program, which is a patient-centered medical home for people with developmental disabilities. It's a clinic, it's a managed care organization, and a capitated Medicaid plan. And all three of these programs have shown improved outcomes for the patient, reduced costs for the systems involved. So from my perspective, achieving affordable care is really is doable, but it's not doable as one organization. It really is going to take each of us bringing forward these innovations to the collaborative and finding ways that we can work together collectively to scale these programs up.
Yeah, it's great. So I'll just add one thing. I think it's important to note that the collaborative, and there's a distinction that's worth addressing, we don't drive affordability. We are stewards of this plan to achieve affordability, and we rely on community-owned efforts to accomplish that. And RyLee kind of made note of that, and it's just really fun to even hear you talk about your 3 initiatives, because I'm very familiar with them now after we have these submissions, and just great things are happening. So.
Great. Thank you. Let's go ahead and move to the next question, and I think our countdown clock might be cutting our time short. So it says we need to wrap up in about 6 minutes, and I think we have a little more time than that. But let's go ahead to the next question. On the One Utah Health Collaborative website, there are some really energizing assertions, and they're very ambitious. One of them states, and Jamie, you showed us this in your slides, Utah will lead the nation in affordable health care that, and I'm going to kind of underscore this next phrase, that improves the quality of life for all Utahns. How will the collaborative measure progress against this auspicious aim? Any comments about that? How will we know if we're kind of moving up that leaderboard?
Yeah, so we intend by the end of the calendar year to come up with a benchmark, a metric by which we measure our progress. We have engaged the Kempsey Gardner Policy Institute to help in these efforts. It's important to note again, and I keep circling back to this, but this is not a benchmark by which we measure the collaborative's progress. This is a benchmark by which we measure the state's progress. And so, without getting into the details and staying kind of high level, there are some states that have executive orders or policy requirements to gather data to achieve what we're trying to do. I think back in 2010, Massachusetts started this. There's several states that have done a pretty good job at narrowly defining their metric. So this is what we're doing. We need to gather the data, aggregate, and come up with this benchmark. And then because we are consensus driven, we'll approach our community board and the community to set a growth target. An ambitious but realistic, achievable growth target. And clearly we want this target to be a figure that's less than general growth in the economy. And I know that sounds really ambitious, and there's probably a lot of people that are staring at me like, I'm up in the night. But this is what we're going to promote, and this is what we're going to aim for. But again, we will only move forward with consensus from the community board and the community. So that's some idea about how we can start to measure cost and outcomes. It's this cost containment initiative that's at the heart of the collaborative and one of our primary focus areas right now.
So it sounds like the collaborative will be the steward of that benchmark and of the measurement process to ensure that the state's making progress.
Yes, that's right, Rebecca.
I'd like to add that from our lens, one metric of progress that's really critical and key to us within the Department of Health and Human Services is that the individuals who live in poverty are a true measure of success of this program. As we know, that individuals who are living in poverty are underserved. They often experience greater disease burdens, poorer health outcomes, and have greater challenges than maybe the general population. And I think an important marker of success for us in the health collaborative work that we're engaging in is ensuring that there is a measure of improvement across this vulnerable population as well.
It's striking in that quote from the website, Jamie, from your slides, it references all Utahns in all geographies, and that's exciting and inspiring. All right, so moving on, Jennifer, I'm going to direct this next question to you. As Medicaid Director, can you describe the role of the Department of Health and Human Services in the collaborative?
Yeah, thank you. So we were really excited to partner with the Health Collaborative in making 3 commitments that we believe will promote the health of Utahns served through the Medicaid program. Today, more than 500,000 Utahns do receive their health coverage through the Medicaid program. These are vulnerable Utahns, low income, And the dollars invested in services from the Medicaid program should translate to outcomes and good quality of life for these individuals. I think there are 3 core principles that really are rooted in our foundation of how we want to approach the work and the commitments we've made through the collaborative. And the first is whole person care. While a person may have to navigate their health benefit through a physical health benefit, a behavioral health benefit, an oral health benefit, we really want to embrace whole person care as they journey through this and receive their health care, because that's how the person will experience the greatest result. Secondly, data is a critical foundational element of really understanding our population and helping it guide the work that we do and inform us so that we can make course adjustments, we can make interventions where needed and really drive quality programs. And then last, I'll mention that health equity and really designing programs that understand gaps and barriers and actively work to address and close these gaps is critical to this. And we can accomplish this through many different mechanisms. But specifically when we look at the 3 commitments that the Medicaid program has made in the Health Collaborative, our first is around prevention. That all Utahns who receive their Medicaid health benefits through the Medicaid program will have access to an increased use of preventive services. We know this makes good sense. First of all, evidence-based prevention does translate to reduced chronic disease burden later in life. And so this will help individuals who receive preventive services live healthier, more productive lives. This is also a cost savings investment, right? So it aligns with those principles of being cost effective. And we're really excited to roll out a number of programs focused on infancy to adulthood around well-child visits for a young child, immunizations. Through our legislative session this year, we are so excited to roll out robust family planning services for individuals who may not receive access to comprehensive family planning services. We also are so excited to extend family coverage of our pregnancy benefit for up to 12 months postpartum. So individuals, after they deliver, are able to continue to receive care through the first 12 months after they deliver, so that they can receive care for conditions like depression and diabetes, for example. Other things as well, comprehensive dental care came through this session, as well as, really important piece, adult wellness visits. The second commitment that we have made through the Health Collaborative is that the Department of Health and Human Services commits to improve the health of Utahns on Medicaid by advancing the design and delivery of integrated, coordinated care approaches that are person-centered and outcomes-driven. So this goes back to the whole person care approach. We know today that when a person interacts with an integrated model, gaps in care can be closed. They have improved overall care, and in fact, they are more likely to engage in their care. It also reduced costs. So we are really excited to promote the design and the advancement of integrated models that are evidence-based and quality-driven with outcomes that will speak to that. We have many of these in place today, but one example we are actively working on is our reentry program to promote the successful transition of individuals from a correctional setting back into the community. And we're really excited to engage in this work and partner with the Health Collaborative in achieving these goals. Okay, last. DHHS, the Department of Health and Human Services, has made a third commitment whereby we commit to improve the sustainability and the transparency around quality of care by implementing quality payment incentive models. Much of our Medicaid payments today are based on outdated fee-for-service reimbursements, and we are committed to designing programs and services that are outcome-based and also reimburse on value. And we are rolling out programs this year, effective July, that will implement these steps in both our accountable care organizations and as well as our hospital-directed payments.
And Jen, I'm going to pose just a quick follow-on question, the same question as I posed to Jamie. How are you going to measure results against these goals?
Yeah, great. I think an important piece of this work is that we begin with thinking of the result we want to accomplish. And so I'll just say holistically, as we first presented our objectives around affordability and outcomes, and this disconnect that we're experiencing in healthcare, and specifically in our vulnerable populations who receive their benefits through Medicaid, we're going to use data, we're going to use collaboration and connection with our partners and our stakeholders to achieve these goals, but we're going to use data to monitor our outcomes. So as programs are introduced, we will carefully design these programs to know how we will monitor their success. We'll seek input, we'll navigate and change direction as needed as we receive information to do so, and we'll be focused on our end goal, which is outcomes of care for the individual, and of course cost savings and affordability.
All right. So another stated goal of the collaborative is to drive equitable care, regardless of race, ethnicity, sex, geography, or background. Would one of you share your vision around the collaborative's role in supporting entities within the state in driving equity?
Yeah, for those of you that know me, I've been waiting for this question. So,
This is RyLee's question.
this is my question. Yeah, so I think from my perspective in the work that I do as a community engagement director for a health system, is there's two things that I really want to see the collaborative focus on. And so the first is to encourage better data collection and coordinate better data collection. And the second is to bring community to the table. And so I'll take a minute, if I may, to talk about both of those things. So the first, driving, in order to improve health outcomes, we need better data, and that's just it, right? Like, and I'll give an example within our health system how we have addressed that. But I do want to give a shout out to the Office of Health Equity within DHHS and Dulce Diaz and her team. If you saw earlier this week, there was a State of Reform article that she participated in about the state's efforts to better collect race and ethnicity data, and she'll also be speaking about that later today on a panel. Plug for Dulce in that panel is efforts to ensure health equity across the continuum of care. So please go check that out to learn more about this. I'm sure she'll discuss the race and ethnicity data collection efforts. But so for University of Utah Health, we really want to focus on accurate and self-reported data. And this is really to create visibility around where disparities may exist. So if we can't see them, it's really hard to address them. And so let's see, so that allows us to create better inclusive care plans and then to work towards those more equitable health outcomes collectively. So it's really, for us, like we experienced this through COVID-19, and we saw that nearly 30% of our patient population, we didn't know much about their race and ethnicity. So it was really hard when we were seeing nationally and through the state data that people of color were experiencing disproportionate impacts of COVID-19, whether that was death rate, access to vaccines, contraction rate. We knew that these disparities were existing, but then it was really hard to do something about it because we had a large portion of our population we didn't know much about. So we did what we could for the population that we knew much about, right? But then we knew that there was this lingering population we wanted to help, but we didn't know how exactly. And so now what we have done at University of Utah Health, and in partnership with the Office of Health Equity, we've taken up some of their recommendations. We're going to start in the spring only asking one race and ethnicity question instead of asking two, which eases the confusion about the difference between race and ethnicity. And it's all really complicated and nuanced to an individual and how they identify. So it reduces that nuance. And then y'all are gonna probably gasp when I say this number, but we're gonna have patients have the ability to self-select from a race options of over 90 races. And that is up from about 10. I think it was 7 is what we had originally. And the reason for this and how we came to that number is we looked at the state demographics of Utah, and we really tried to reflect what we were seeing across the state and how people identify. But then we also looked at where our new Americans were coming from, immigrating from, because we see a very high number of new Americans within our health system, both at Redwood and at our forthcoming population health center. And so this is going to adjust over time, It's not the final list, and we are as people start selecting more data, we can make sure those options are there, and as we see that people are not selecting certain data, we can reduce the list. But for those of you who have worked on identifying a race list, it is hard because you want to include everybody, right? You want people to see themselves in that data, because that is the community feedback we hear, is that when you only have 7 options, I don't identify as any of those, and you only let me select one. And I have parents of multiracial backgrounds. And so it was really important that people could multi-select, they could self-select, and they had a lot of options that they could choose from. So we hope to see, hopefully next year I'll be back in a panel talking about how we reduce that 30% down to less than half of that. And hopefully, 0. We'd love to know more. So anyway, I think my point being that if health systems and the state of Utah are working to better collect data on race and ethnicity, sexual orientation, gender identity, and New American status, then we can collectively, under the auspice of One Utah Health Collaborative, start to identify what those health disparities are and how we can work together to achieve a more equitable and accessible healthcare system for the entire state. Whew. Okay, see, that was exciting for me. And then the second thing I want to talk about, which I'm also very passionate about, for those of you that know my background, a lot of what I've done over the years is to really try to bring community to the table. Whether that was on Medicaid expansion or working on the University of Utah's West Valley Hospital Now and other projects, it's really the community voice that makes a difference. And I do feel that the One Utah Health Collaborative has done an amazing job at getting health leaders, health systems, industry leaders involved and engaged. But I think we're at our infancy in terms of how do we actually engage community members, the people who are experiencing the high costs, the people who are experiencing complicated health systems and navigating those systems, the people who might be limited English proficient. And how are we engaging them? Because oftentimes they're living the day-to-day, right? They're experiencing this, and the folks who are in the community often have the solutions already. They know what their barriers are. They know how to address them, and if only the health systems would listen, right? And so I think it's really important for us to now move towards an eye towards engaging community, bringing them to the table, to the conversation, or having the collaborative go to the community where they are, even better, right? And engage in that dialogue and conversation with them. And so it's really about how us as health systems can change, not necessarily about how we try to change the consumer behavior and the patient behavior.
So from both Jamie and RyLee, I hear an invitation, join us and share your perspective, or we'll get to you and because you want that perspective. Any other comments as we wrap up the discussion about equity?
I would just say every decision that the collaborative that is made will be done through the lens of equity. This is what brought me here. It's where my heart is. I can't articulate myself as well as RyLee just did. But when you spend 25 years in federal law enforcement and you're in the trenches, so to speak, you're exposed to a lot. Behavioral health issues, substance abuse disorder, working a lot with marginalized populations, whether that's migrant workers, refugee community, you name it, you just see a lot. And that's what inspired me to pursue this position that I now have. And it will drive to every decision that we make. We will look at outcomes and affordability through the lens of equity. We know that we need to be data-driven, but when you can storytell and you show, examples, one with a project that was shared with me where we already have some momentum of a single mother living in a tent in her grandmother's backyard who's pregnant and doesn't have coverage and access. And then you have an employer that steps up and assumes ownership, and suddenly that person's covered, and one of their regional managers is almost brought to tears saying, "I've never been so proud to work for business." This is one small example of how we need to help those that are vulnerable. So.
Well, why don't we pivot and take a question or two from the audience and then wrap things up. Any questions for this one? We've got a question here. Patrick, thanks.
This is long. Oh yeah. Thank you so much for a really excellent panel. Heather Borski, I work for the Department of Health and Human Services. Can you describe where upstream prevention and healthy communities in the scope of supporting healthy individuals and reducing healthcare costs from that very upstream perspective fits within the work of the collaborative and the collaborative's metrics?
So I'll quickly address this. Really important. We know that there are tremendous cost savings, right? Reduction in ED visits, right? Reduction in hospitalizations. We know where the system is spending its money, right? And so upstream efforts are critical. We just highlighted Medicaid in our last newsletter with wellness program for adults. And they managed to accomplish something that a couple local systems, hospital systems that have come to me, providers that are trying to do the same and work through a payment model for payer groups to achieve this. But we're seeing it, and so again, that's just one example of this incremental change as things start to mount. But we know, and what's so great too, in a very complicated system, upstream efforts, when you learn about it, you go, like absolute common sense, right? Healthy eating, exercise, imagine that, diabetes prevention, obesity, everything else. So, no, it's also very important on the radar, and we have several efforts that we're looking at right now, supporting with submissions that have been sent to us.
Great. Another question right here. Excuse me. Okay. Let's take both. Let's go with Dr. Lining, and then we'll go with Patricia Doxson. Welcome to both of you.
Thank you. This is it. And I have the privilege of having known Rebecca Nielsen since junior high school, and she has always been an absolute rock star.
And I had a really messy room in high school, and Mark knows that.
Cleaner than mine. So I'm an internal medicine physician. I'm the CEO of the People's Health Clinic. And RyLee and Jennifer, your comments mean a lot to me. I am on the front line. Most of my patients are undocumented residents, and the upstream factors that they face are profound. In fact, 2 weeks ago, we published an original article on our diabetes program, and what we found is 58% of our patients were food insecure. So I can't recommend healthy food access if there is no health access. They're also often labeled as non-compliant because they don't have transportation to appointments, and many of my patients are actually labor trafficked. When I look at all these factors, and I hear you say the word all Utahns, my question is, are there intentions with the One Utah Collaborative to actually offer Medicaid to all Utahns? I know there's been a recent change through Senator Luz Escamilla's Cover All Kids policy.
I feel like I've spoken too much.
Yeah.
RyLee or Janet, if you guys would like
I'm
to.
happy to respond to this. We are really excited to implement this coverage option for children in our state who may not meet normal coverage requirements through Senator Escamilla's work, and we'll plan to implement that later in this year. When we say all Utahns, it does encompass these individuals and others as well, and certainly this extends beyond Medicaid, right? Extends beyond the scope of Medicaid, but when we do work within the Medicaid program, touching specifically on the items you addressed, looking at health-related social needs as they address food security, housing, and those factors that are certainly essential elements of a person's health. We have stood up a program just this past year that does offer housing support services to individuals who qualify. These are adult individuals who are in our expansion program who are chronically homeless. and they are able to get support to have housing security, and it helps support first and last month's rent. It provides coordination, so individuals have support in understanding what lease agreements are and how to actually get a rental unit and be able to stay there. It also supports a person with getting utilities and some basic household items. So these steps are steps of progress towards these essential needs of housing and food supports. And certainly we're looking forward to other services like medical respite services, which are in-home supports and provide housing and also medical respite services for individuals who would otherwise be homeless and not have a place to receive these services. So to address your question just directly as well, these are small steps of change. But we are focused on this. We are acknowledging that these are direct factors that influence a person's health care. And as we implement these programs and offer them to individuals, we'll be reporting out on the outcomes of the individuals who are able to access them. So,
I'll just real quickly, I want to just make an empathetic comment, and it's not necessarily going to answer your question, but do recognize I'm on the board of the One Utah Health Collaborative, and it is certainly something that I think about a lot. But there's a certain dignity that comes with coming through the front door of a health system, right? And I think there's a lot of Utahns that aren't afforded that dignity. And I think there are things that we can do about it incrementally and over time, and we've seen steps taken this last year towards that, right? With the kids and then federally with the DACA, individuals being able to access Medicaid. I would just remind people, and maybe, hopefully I don't regret saying this, but you know, we pay for it as taxpayers anyway, right? Like, they go to our hospitals, they oftentimes put off care until they're in our emergency departments. Oftentimes we are paying for it, we're just paying for it in an indirect way. And we're donating to clinics like the People's Health Clinic. We have federally qualified health clinics, and so they're receiving care, they're here, we're paying for it in one way or another, and so how do we make sure that we afford people the dignity that they deserve?
Thank you. Patricia.
I also had a messy room in junior high.
Raise your,
But all three of you mentioned the goal of collaboration, and it's in the title, collaborative. I'm just curious, there are so many reasons why collaborating in healthcare is difficult, but let's say you could solve any of those challenges. What collaborations with University of Utah Health or Medicaid do you think could make the biggest impact if you could overcome all those barriers overnight?
Where to begin? Well, we know how important alliances are, right? If you look, so I have a daughter in Poland right now, of all places, and if you look at the NATO alliance, that's especially meaningful to a guy like me as I sit here. We need to feel this common pain and look at these alliances where groups can come together. To answer your question, if there's any one top of mind, you know, we had a dinner last night and we talked about top of mind with many folks that were going to attend the conference today, and behavioral health happened to be maybe the most common denominator in those, or commonly answered question. But I think data interoperability right now, I mean, if we look at big health systems, system-wide change, data exchange is crucial. And the cost savings that come from that, the equity that we gain for a consumer, a patient that's sitting in front of a physician with data, real-time data available, like, would be incredible. And we have this vision of this longitudinal, right, assessment, one record that I'll talk about. That would probably be top of my list.
I would echo your statements around data, collecting the right data, having standardized data sets for reporting, looking at those outcomes as far as a really meaningful step of moving forward with our efforts to accomplish our goals through the collaborative.
Yeah, I mean, I don't know that I have much to add. I think that that's where a lot of the momentum is right now, and so that's where we might see an early win. For me specifically, like, I really look at how we do all have different data sets and we're collecting, you know, different information, but it's really hard to share the data. And so, as I mentioned in my comments on the race and ethnicity question, it's like if we can really look at the whole data set, what we have on our patient information, what the criminal justice system might have on theirs, and the foster care system might have on their data, right? Like then we can start to really look at a whole person and not just the one view that we have into that individual. So I really do think the interoperability and the opportunity for data sharing is there.
Well, our hour went quickly. Thank you so much for your questions. If you have questions, yeah, please feel free to approach the panelists. They leave the stage, but I'd like to extend my heartfelt thanks to the panelists for their comments and to you for your participation. We hope to see you for the closing keynote this afternoon with Tracy Gruber, the Executive Director of the Utah Department of Health and Human Services. Have a wonderful day, and we'll see you then.